management in this patient. A 55-year-old man is brought to the emergency department due to shortness of breath and weakness. The symptoms have been present for approximately 3 weeks but have worsened over the past 2 days. Okay. He has felt too weak to get up to use the bathroom today. The patient was diagnosed with non-small cell lung cancer 2 years ago. At that time, he underwent surgical resection followed by cisplatin-based chemotherapy. Since then, he has had follow-up CT scan every 6 months without any evidence of recurrence. His last CT scan was 5 months ago. Other medical history includes MVP, for which he has been followed with echo every 3 years. The patient used to take antibiotics prior to dental procedure but stopped a few years ago when his cardiologist advised him that it's no longer necessary. He currently takes no medication. His mother died of diesel mechanic. He was formerly a diesel mechanic, retired at the time of diagnosis, cancer diagnosis. Patient does not use tobacco, alcohol, illicit drugs. He worked as a diesel mechanic but retired at the time. Temperature is 37.8. BP is low and he has tachycardia. Lungs are clear to auscultation. He has 1+ pitting lower extremity edema bilaterally. Bedside echocardiogram shows moderate pericardial effusion. Which of the following best confirms the need for invasive management in this patient? Early diastolic right ventricular collapse on echocardiography. Let's have a look at this. Early diastolic collapse. I don't think so. What is this referring to? Early diastolic collapse. I'm not sure, but I don't think it's the right answer. Increase height of JBB on expiration. So that's Kussmaul's sign. That could be I could say this right. Inspiration fall of 8 millimeters of mercury in systolic blood pressure. That's completely normal. If it's more than 10 pulses paradoxes, large V wave and JVP jugular venous pulsation, ACXVY. So atrial contraction, relaxation. I don't know about that one. Low QRS complex on. I think there's alternative. I'm gonna go with B. I could be wrong here. I'm wrong. Damn. Early diastolic collapse on expiration. Okay, so cardiac tamponade. All right. So we can see blood in the pericardial space. So we can see large ventricular rupture and the cardiac surgery. So which he didn't have. Pericardial effusions, malignancy, infection, uremia. Okay. Cardiac tamponade results in the increased hydrostatic pressure in the pericardial space, leading to impaired diastolic filling on the right side of the heart. This patient's moderate pericardial effusion, which raises concern of recurrent lung malignancy, has led to subacute cardiac tamponade. Okay. So you could have another lung infusion. Okay, so okay. Let's look over here. Early diastolic collapse of the right ventricle and right atrium. Other consistent okay. We can see the echocardiogram visualizes pericardial effusion, most specific tamponades, early diastolic collapse of the right ventricle and right atrium. Okay. Let's look at JVP. Increase during expiration is normal. Oh. However, if the JVP is increased, but as in the JVP decreased with inspiration due to increased compliance with the right ventricle. Okay, fine. By contrast, Kussmaul is abnormal increase during inspiration. Okay, I read that wrong. So this is expiration. He must have mentioned expiration. Yes, I read that wrong. Okay, A. So subacute cardiac tamponade is going to progressive dyspnea, and this is going to be early diastolic collapse of the right ventricle and right atrium. It's specific finding for cardiac. So early collapse. So what does that mean? Early collapse. So this increased hydrostatic pressure leads to impaired diastolic filling of the right ventricle. Okay, this hydro pressures. Okay, got you.